The research project that began this whole thing is about improving how we prescribe opioid medications in primary care to patients presenting with acute or chronic pain. The idea being that we want to give them the smallest amount of medication for the shortest period of time that's going to allow them to regain their function in as quickly as possible. We had a massive shift in how care was being delivered and how prescribing for people who use drugs was changed as well. So number one, walking into a walk-in clinic or walking into a community center to ask for help, if you're a drug user or if you're somebody who has acute or chronic pain, became extremely difficult. People were terrified of going to the emergency department because they might get COVID. There were significant barriers created in primary care where people needed to engage virtually. So there was confusion about how do I do that? You needed access to technology. There was inconsistent decisions at individual practice levels about who gets seen in person and who can only be seen virtually. So there was a massive increase in barrier to even seeing somebody to talk to them. And then at the same time, there was recognition led by our colleagues at the BC Centre on Substance Use and some of the groups within the Ministry of Health and the Ministry for Mental Health and Substance Use, that we needed to be able to help people who were using drugs, who were having these additional barriers, and who also were now worried about their usual process and exposures that they might have to COVID in their drug using. And could we help them stay safe from COVID? We had two components in this study. One, there was a randomized controlled trial where we created an educational intervention for all prescribing family doctors in British Columbia, where we said to them, hey, this is how you've been prescribing in the last year when you prescribe opioids to patients with acute or chronic pain. And this is how you compare to everybody else in the province. Here's a quick review of the literature, and here's some suggestions that you could consider to make changes to your prescribing practices. We had also constructed a qualitative component of this research where there was an educational webinar where we would review the key messages of that educational intervention that we had sent to family physicians, and then also have focus groups afterwards to ask people about how did these educational messages meet up with them, how did it change their practice. What we found was that participants were not able to hold the two realities of the preventable deaths from the toxic overdose crisis and opioid sparing prescribing for acute and chronic pain at the same time. The messages kept getting mixed up. And so sending a message saying, hey, you should try to minimize your opioid prescriptions was interpreted as opioids are bad. People who want them are bad. Don't prescribe them. And that's a very simplistic, obviously it was a much more rich discussion than that, but we just kept hearing that over and over again, where we tried to say, oh, no, but we're not talking about, people who are using drugs or people who are presenting with opioid use disorder. That's a separate thing that we want you to be treating. It was the discussion, they just kept conceiving those people in the same way and potentially inappropriately treating those people who were using drugs or who were seeking opioid agonist therapy for a substance use disorder. And that was very, very concerning, that we could potentially be creating poorer outcomes for a population that we never even intended to talk about with this particular study. I'm delighted that we've been able to collaborate with several groups. Fred Cameron and the Solid Outreach Group in Victoria, which is a peer and person with lived experience group of drug users. Their intention is to create a healthier life for people who use drugs by providing healthcare, by providing harm reduction, by providing meaningful employment. And working with that group has been an excellent way for us to learn the truth about the barriers that patients are facing versus the narratives or the stories that make it to the media. And having that information present, and Fred being such an incredible spokesperson and able to access the stories of his colleagues and informants has been incredibly valuable. We've also worked with the Therapeutics Initiative at the University of British Columbia. This is a group that provides prescribing information and education across British Columbia. And they were able to help us with the quantitative component of the research study in terms of putting the tool together, the educational intervention. And then the BC Centre on Substance Use has a vast array of expertise that they have been able to lend to this project in terms of connections with drug using communities, people affected by those who have died from toxic overdose, and education initiatives already going on in the province. And they've also been great at helping circulate messages as we have been learning them to the communities. So having those different groups that we have been able to work together has been absolutely amazing. And they've been very energized in having these knowledge translation conversations within our own team that we then hope to continue to be able to project outwards as well. For the people who showed up for the dialogue session, the seemingly adjacent topics of racism, colonialism, poverty, housing insecurity, lack of a coherent, safe supply approach by federal or provincial organizations, and stigma related to drug use are all incredibly important factors that need to be considered in any research initiative that is looking to educate prescribers and improve outcomes for patients.